Let's start this session. Today we are going to talk about the thyroid cancer part 2. And today what we are going to talk about is the medullary carcinoma of thyroid. So mainly we are going to talk about the medullary carcinoma of thyroid. Okay, so that is the primary focus for today. Okay. Now, overall, if you would like to say, so this particular thyroid malignancy is uncommon. It constitutes to around 2% of all the thyroid cancers in the US. Okay, so as you can see, it is not the common one. And we already saw that day that what is the most common thyroid malignancy? Papillary carcinoma of thyroid, right? What is the second most common? Second most common is your follicular carcinoma of thyroid, that is around 11%. And then we have a medullary carcinoma of thyroid, which is around 2%. Okay. Now, it was first described as medullary by Hazard et al. In 1959. That's fine. Even if you don't remember it, it's absolutely okay. Now, from where does this particular medullary carcinoma of thyroid arises? Okay. So, medullary carcinoma of thyroid, it basically arises from your parafollicular C cells. Okay, so it basically arises from your parafollicular C cells. Okay, now what are these particular parafollicular C cells? I am pretty sure that all of you know that in our thyroid, what do we have? We have a thyroid follicles. Okay, so in our thyroid gland, what do we have? We have the thyroid follicles, and then we have the area which is between these particular thyroid follicles. Okay, so we have these particular thyroid follicles, and in between these thyroid follicles, what do we have? We have parafollicular C cells. Okay, so these parafollicular C cells are the ones from where we have this particular origin of a medullary carcinoma of thyroid. Okay, so in between these particular thyroid follicles, there are parafollicular C cells. From there, the medullary carcinoma of thyroid it arises. Now, these parafollicular C cells they secrete a hormone which is called as a calcitonin. Okay, now if I want to ask you that this calcitonin, what is the role of calcitonin? Okay, so what does this particular calcitonin does? So what you need to understand is that the calcitonin is an hormone which is basically responsible for reducing the calcium levels in the blood. Okay, so we have two. One, we have parathyroid hormone, another one is a calcitonin. Parathyroid hormone basically increases the calcium levels in the blood. On the other hand, the calcitonin, it reduces the calcium levels in the blood. So that is the main role of your, what do you call as a calcitonin. Okay, so we'll come to that. Now, this medullary carcinoma of thyroid, this can be either sporadic. Okay, sporadic means like we don't have any familial association of this, but it happens in the general population due to some or the other reason. There was some kind of a mutation which happened that has led to the malignancy. Okay, so yeah, it can be sporadic, and that is what is the scenario in around 75% of the cases. Okay, so 75% of the cases of your medullary carcinoma of thyroid, what is it? It is sporadic. Okay, it is sporadic. On the other hand, in around 25% of the patients with the medullary carcinoma of thyroid, it is hereditary. Okay, so what are the syndromes which are associated with the medullary carcinoma thyroid? We have MEN2A and we have MEN2B syndrome. Okay, so we have a MEN2A and MEN2B syndrome. These are the ones which are associated with hereditary medullary carcinoma of thyroid. Okay, so I'll kind of summarize it what we saw. Okay, it is not that a common cancer, that's okay. It arises from parafollicular C cells, and these parafollicular C cells are responsible for the production of calcitonin. Calcitonin reduces the calcium levels, and that is what we are going to talk about. Now, it is sporadic in around 75% of the patients, hereditary in 25% of the patients. In the hereditary, we may find the mutations of either MEN2A or MEN2B syndrome. Okay, now that's all about the introduction of this. Now, let us talk about the clinical presentation. Okay, so how will the patients present to you and all those things? So 75% of the medullary carcinoma thyroids, as I told you, they are sporadic in nature. Okay, so they are typically diagnosed between 40 to 60 years of age. Okay, so they are typically diagnosed between 40 to 60 years of age. Okay, sporadic. Now, common presentation is palpable neck mass. Okay, so yes, obviously, if at all there is a thyroid malignancy, what the patients can have is a palpable neck mass. There can be some kind of a nodule in the kind of what you call as the thyroid, which can be palpable, right? That's why there can be a palpable neck mass, or there can be cervical lymphadenopathy. So lymph nodes of the neck, they can also be enlarged. Okay, so or there can be cervical lymphadenopathy. So these are the cases. These are the things which may be present. So around 50% of the patients, what we have is a cervical lymphadenopathy. Now you understand my point? So what we have is cervical lymphadenopathy. Okay, so typically diagnosed between 40 to 60 years, sporadic. palpable neck mass and cervical lymphadenopathy, this can happen. Metastasis can happen either to a cervical node, that is in 70% of the patients, but at the same time, it can also have a distant metastasis to places like the liver, to places like the mediastinum, lungs, and the bones. Okay, so in the bones, what kind of metastasis do we get? So please remember here, what we get is a osteoblastic metastasis. Okay, in the bones, what you basically get is a osteoblastic metastasis. Please remember this. Okay, right. Now, there can be unusual, like usually they are unifocal. So this is the basic difference. Okay. So you understand what's a unifocal? That is, it's arising from one particular part of a thyroid gland. Okay. Now, yes, like most of the times, usually the sporadic medullary carcinoma of thyroid, they are unifocal. Okay. Now, yeah, commonly they are basically present in the superior and the lateral thyroid lobe. Okay. So superior lateral thyroid lobe, this is the location for your sporadic medullary thyroid cancer. Okay. Okay. Right. That's what you need to understand. Now, talking about the hereditary. In the hereditary, what do we have? We have a younger onset. Obviously, because if at all there is some kind of a genetic mutation which is present, then this is going to give you a younger, like these are the patients who are going to occur at a young age group. So younger onset, familial medullary kind of thyroid cancer. This is basically MEN2 syndrome. MEN2A, MEN2B, all those particular things are there. Now, MEN2A is typically presents at around third decade. Okay. And the MEN2B, it typically presents in around second decade. So in around 20 to 30 years of age, the patients are going to develop the thyroid malignancy. Okay. So yeah, MEN2B, it is even more younger. So sometimes even in the infancy, the patients might develop a medullary thyroid cancer. This is the first difference. That is, the age is occurring at a lower age, younger age group. Then often it is multifocal. Okay, so what you need to understand is that this, what you call as sporadic cases of the medullary thyroid cancer, they were what you call as unifocal, but here it is multifocal. So it can arise from multiple areas of a thyroid. It can be identified early through the genetic screening. Okay, so what we can do is we can either do a genetic screening. Okay, so genetic screening can basically help you in this. Okay, so what about the genetic screening? So what we have is, yeah, like we look for the red proton gene, and yeah, that is how we can diagnose these particular patients a bit early. May present during the workup for pheochromocytoma or primary hyperparathyroidism. So what you need to understand is that in the patients with the MEN2A syndrome, what are the other associations? The patients can have a hyperparathyroidism, okay, in the MEN2A syndrome. In the MEN2B syndrome, what you have? In the MEN2B syndrome, what all you have is a medullary thyroid cancer, okay? All you have is a medullary thyroid cancer. In the MEN2A, again, you have just the medullary thyroid cancer along with the hyperparathyroidism. In the MEN2B, there is no hyperparathyroidism. It is only the association is the medullary thyroid cancer. So, okay, like medullary thyroid cancer with the pheochromocytoma. Sorry. So, medullary thyroid cancer is going to be present in MEN2A and MEN2B both. But in MEN2A and MEN2B, the patients can also have pheochromocytoma. So, occasionally the patients can have a sporadic hypertension. Patient will be diagnosed with the pheochromocytoma. And yeah, that's what you need to understand. Okay, so important. Now, symptoms due to hormone secretion. So, what are the symptoms which the patients can come to you? Diarrhea, flushing, and the weight loss. This is because of the elevated calcitonin level. Okay, so frankly, this is the most common presentation. Okay, so diarrhea is the most common presenting feature of your patients with medullary thyroid cancer. Now, rarely the patients can have paraneoplastic syndrome. So this you can remember. What is the paraneoplastic syndrome associated with the medullary thyroid cancer? It is a Cushing's and the carcinoid. Okay, so Cushing's and the carcinoid, these are the paraneoplastic syndromes which are associated with what do you call as thyroid cancer. Okay, yeah, medullary thyroid cancer. Okay, now this is a table. I'll come to this. Okay, I'll come to this. Okay, okay. So let's first discuss the theory, then we'll talk about the table. So red gene, where is it located? It is basically located on the chromosome number 10. Okay, so 10q11.2. This is the location for your red proto-oncogene. Okay, now what it does is it basically encodes for a tyrosine kinase receptor regulating cell growth. Okay, so this is basically associated with the tyrosine kinase receptor regulating cell growth. Okay, now more than 100 germline mutations identified in the hereditary medullary thyroid cancer. More than 100 mutations are basically present in the hereditary medullary thyroid cancer. Now, what is the type of mutation is going to determine the level of aggressiveness of this medullary thyroid cancer. Now, this is something which you should know because when you are preparing for your what you call as an EPG, you might not have even heard of it. Okay, so let's kind of talk about this. Okay.